So let's think about why this is so important. And can I say how excited we are to be here at the World Health Summit to launch this really important work. It's really important that everyone understands that there are resources available that enable you to look at health systems, how they operate, and to help meet the needs of populations in those countries. These data can help serve policymakers who can actually understand where their country's health system and challenges are up to. It's systematic, it's scientific, and what it does is look at the comparative magnitude of health loss due to diseases, injuries, and risk factors by age, sex, geographies, all the way from 1990 to 2023. Something we are really proud of, and I think probably this is really hard to actually beat. This study involves more than 17,000 collaborators around the world. That's in 167 countries and territories. Collaborators who contribute by bringing their data, by critiquing their results, by vetting models and estimates, and by sharing data, publishing results, and have we got it? And most of all, actually engaging in the work. Now, for this session, you will see there is a QR code, and I'm sure everyone is sufficiently IT literate, that you can use that QR code to actually pull up a series of resources. We're going to have a couple of surveys during the course of this, but importantly, you can also look at this to actually see the GBD compare if you want to actually look at some of these results. I would, however, also, though, ask you, rather than staring down at your device for the whole session, that you actually listen to what some of our colleagues have to say about these results. So these results, this publication is seminal. This is the first time we've launched this at the World Health Summit. I have to say, I am particularly delighted. I've been advocating for this for some time, and I hope you will find it as exciting as we do. To give you a sense, now my button isn't working. Can I have the next slide, please? Nope. Anyway, there's a slide in here somewhere that actually gives you a sense of the global reach of the worldwide collaboration. There it is, thank you so much. And you can see exactly how widely spread the collaborators are. And for those in this room who are our collaborators, can I thank you for your work? Can I say how much we value it? And can I also encourage you to keep doing that work with us? Let's just look at the next slide if we could, please. Thank you. This gives you an indication of the GBD compare. So if you wish to pull up that resource, this is what it will give you in terms of looking to see how the data operate. And without any further ado, what I'd like to do is introduce to you Chris Murray, who is our director. And Chris is going to take you through the first part of the results, and then we will be hearing from the panel we have with us today. Chris.
Hope this works. Thank you, Jane. Let's see if the clicker works. No. Oh, there we go. So I'm going to speed through some high-level results, and then as each panel comes on, I'll pop back up and give a few results relevant to that panel. So first off, in one of the papers, part of the GBD, we do a full demographic analysis of fertility, mortality, population from 1950 to 2023 for 205 countries and territories and subnationally broken down for 20 countries. One high-level finding here is life expectancy at birth. And you can see the huge spread. We have a 30-year range for life expectancy for both sexes combined, from Central African Republic at 55 to Singapore at 85, with a particular concentration of low life expectancy in the Sahel and in Central Africa. Now, another way we like to look at in the GBD is with tree maps. These are rectangular pie charts. This is showing the proportion of burden by cause back in 1990, and here we're measuring burden using disability-adjusted life years, a measure of healthy life lost. And back in 1990, the communicable maternal and neonatal causes, the causes associated with poverty, accounted for the largest share in the red colors. Things like neonatal mortality and causes, malaria, pneumonias, diarrhea, and measles. And then the non-communicable diseases were closer to 45% of burden, dominated by things like stroke, ischemic heart disease, congenital disorders, or chronic obstructive pulmonary disease. When you go to 2023, the blue boxes have massively expanded, representing this huge shift globally towards non-communicable disease, and you start to see a much more prominent role for diabetes, for chronic kidney disease, for some of the mental health disorders. Anxiety and depression are larger, certainly, than they were in 1990. And you see a shrinking of the communicable maternal and neonatal causes, but the emergence, compared to 1990, of HIV, and important contributions in the injuries in green for falls, self-harm, violence, and road injury as well. Now, on the next slide, we shift, sorry, go back. Sorry about that. We have the second view that the GBD provides, which is risk factors. There's more than 80 risk factors in the Global Burden of Disease study. And for each risk, we analyze by location, taking into account the evidence of risk and exposure, what is the burden that's related to the leading risk factors. And at the top is malnutrition, both child and maternal. But then we have high blood pressure, air pollution, tobacco, diet in aggregate, but there's 15 components of diet, high blood sugar, and high body mass index, namely overweight and obesity. Amongst those top 6, as you'll see a little bit later, you have some of them going up, most noticeably overweight and obesity. Now, we'll talk about children. Zulfi's going to talk to us about challenges around children. And here's another way, maybe different than we're used to looking at, but again available in the GBD, of the probability of death between birth and age 20. So this is children and adolescents, showing you for World Bank income groups on the left, the huge progress we've seen, huge declines. But despite the huge declines in all 4 income groups, we still have a 10-fold variation in the risk of death between birth and age 20 from low to high income in 2023. And again, this concentration of high probabilities in the Sahel and somewhat in Central Africa. We're going to talk about NCDs. I showed you the macro transition at the global level, but if we look by income group, World Bank income groups, you can see that the biggest increase in the share of burden due to NCDs on the left has actually been in lower middle income countries, from a quarter of burden to 57% of burden by 2023, and also in the upper middle income countries in green. So huge transitions, but particularly intense in the middle income world. And I'm going to end on this first panel of slides from the GBD with a reminder that we also need to think about burden now and in the future, taking into account fertility, which is the driver of population change. And the fertility rate remains over a total fertility rate of 6 throughout the Sahel and extending over to Somalia. So we'll have a discussion about this concentration of high burden, high fertility, and a number of other factors coming. Over to you, Jane.
Thank you, Chris. So we're going to have 3 panels in this session, so it's going to be very lively, but I'm going to try and keep us moving along so we stay to time, because time at the World Health Summit is precious. So we're joined today by, I think, a very distinguished panel, Zulfi Bhutta, Ibrahim Abu Bakr, and Alakros Chiesa. I'm going to say it wrong again. I do apologise. Chiesa. So let's start, shall we? Zulfi, you have very particular perspectives, I think, in these areas, and the really dramatic decline we've seen in child mortality over that period that Chris has just shown us from 1990, particularly from vaccine-preventable diseases and the sort of neonatal disorders that we're aware of. But of course, we know that there are uncertainties. Things are fragile in terms of success. So we've just seen the vulnerabilities that we've all experienced courtesy of the pandemic. What do you think are the interventions that have actually helped drive those gains? What are the things that we should hang on to as being important?
So thank you very much. I must say that, Chris, this year's GBD report is absolutely fantastic. Partly because the methodology is improved so much. Secondly, because you've covered a large span of time, and it gives us also a sense of where we have data gaps, where the quality of the information could be improved. And I think highlighting some of the things beyond the age of 5, much of our interest has been on under 5 mortality, and to recognize that we are really missing the huge burden of mortality that exists from 5 to 14, young adolescent girls. I mean, that I think is a very important finding from this particular report. Now, coming back to the question that Jane has posed. So we do know things that worked over the period of the MDGs. They range from enormous global gains in technology and delivery systems, vaccines. I think vaccines, particularly those vaccines which impact on the infectious disease burden in younger children, have been absolutely revolutionary. There's an anti-science agenda now against vaccines, but no question about it. This mortality reduction could not have been possible without vaccines. Secondly, of course, is better management of the major killers of children beyond the neonatal period, diarrhea, pneumonia. I think the reduction in those burdens come also from better management, better diagnostics, but also improvements in the general environment, water, sanitation, hygiene. But you have to recognize that although the GBD gives us all of these facts and figures and points out to how things might have changed through reduction in risk factors and potentially interventions, some of the best learnings that we have on how mortality has improved in many of these countries come from mixed method studies. So a partner set of studies like the exemplars in global mortality reduction for mothers and children also tell us that about a third to a half of all improvements in mortality reduction could be attributed to things that have influenced poverty reduction, that have influenced nutrition in many countries, that have influenced through education pathways. So I think it's very important to recognize that although the health sector has played a critically important role, it's also those investments outside of health in the social sectors through the interventions that I've mentioned that are critically important. And going forwards, if we want to address things that relate to child and adolescent mortality, it would be very important to recognize the importance of context. The polycrisis settings that you alluded to, Jane. Why is the mortality in the Sahel region all of a sudden staring at us in the face? And it's because they face true polycrises.
Yes.
With climate change, environment, conflict, population displacement, and also a relative paucity of global assistance to some of those countries because they also happen to be very difficult countries to live in.
So let's assume this is an audience full of global health leaders. Funnily enough, it is. And you've got all the relevant health ministers and a few finance ministers as well in this room. What would you say to them would be the things that they could do to accelerate these gains without being subject to future shocks? What would be the couple of takeaways you would give this audience, things that they can do that will actually accelerate for those countries where we still have challenges?
So I would just continue what I said last night at another session, that this current crisis of development assistance is also an opportunity for countries. So my major message would be take charge of your own health systems and your own social systems yourself. Every country in the world, barring a few which are heavily indebted countries, has the capacity to do more. And I think for women and children's health, the first and foremost thing that would make a difference is domestic financing for health. I come from a region where we spend far, far more on defense and other expenditures that we do on social systems, on education, on empowering women and girls, and improving primary care and universal health coverage. So I think that would be my core message. The second would be, as I said, do the right things. Do the evidence-informed interventions. But for heaven's sake, do them right, which means also the implementation strategies to reach the poorest of the poor and marginalized populations. My final point on that, if I may, and I was talking to Chris a short while ago, is really the importance of information systems, data. We're running a situation right now. There was probably a meeting today on what will happen to DHS systems now that all of a sudden there is a panic that these surveys are going to disappear or have disappeared to some extent. I think that's a great opportunity for countries to take charge and move into vital registration systems that are within their grasp. I was talking to you today about how a small country like, I shouldn't say small, beyond the population, like the Kyrgyz Republic, has a birth data registry that covers all pregnancies and childbirths in that country. If they can do that, many other middle-income countries, low and middle-income countries can. So one message to ministers representing different sections is, the eye does not see what the mind does not know. And to make the mind know things, data, and particularly solid information from your own geographies is probably the most important intervention.
Yes, if you don't know, you can't go and you can't fix. Quite right. Ibrahim, the Sahel, we've already heard about the Sahel in this presentation. High child death rates and some progress, but high population growth, increasing burden due to high temperature, something I think we're particularly alert to. And in some countries, challenges exacerbated by political instability. So a considerable fraction of the current and future global burden disease is likely in the Sahel. What do you think the key drivers are behind those overlapping challenges?
Thank you, Jane. So I want to start by thanking you actually for singling out the Sahel, because in so many global meetings that I attend, the conversations is about everywhere else where we're making great progress. I mean, whichever way you look at it, the stark differences in outcomes for people living in the Sahel with the rest of the world is awful, right? It's already been alluded to that this is partly driven by a multitude of factors, a complex set of factors, which I would come back to and discuss one at a time. Those factors are not there simply because people fail to act. It's actually the whole world that has neglected Sahel. And I'll challenge everybody in this room. If you work in global health and you define global health as something to do with inequalities, and you haven't done anything or didn't know anything about the Sahel before today, then you're probably not doing global health. It is important, not simply because people live 30 years at birth, life expectancy compared to Singapore in some countries of the Sahel, but because of the reasons why people die. Kids, neonates are dying for preventable things. When you look at the report, the GBD report, I look in detail as to why is it that there are these big differences in life expectancy. It comes down to the things that other countries have made progress in: communicable diseases, neonatal conditions, nutrition, things that we know how to prevent, right? We know about vaccination, we know they work, we know how to deliver them, we know how you do WASH, and we've delivered them successfully around the world. The reasons why they are not happening is A, governance and the weak states that have already been alluded to, and the ability of those states to effectively deliver for people. Weak health systems as a consequence of governance. So we have lots of countries in the Sahel where the health system isn't able to effectively reach the poorest and give them vaccination or access to healthcare. Anthropogenic climate change, and all of us in this room with our carbon footprint are responsible. It isn't the people in the Sahel. The Sahel historically has actually been a carbon sink, and because of our actions and the expansion of the Sahara, that is reducing the ability of the Sahel to help us reduce global warming. Instead, what do we have? We have the encroachment of the Sahara, increasing temperatures, and reduction in resources among the people of the Sahel. So they have no choice but to migrate out of their native lands, which was not historically the case. Compounding that, when you are at low skill set, low opportunity to develop, what do? You have kids. You grow your family because you need people to grow. That's what happened here in Europe a long time ago. People had lots of kids. It's not because they don't know. They need people to work in the farm, so they have 6 kids, right? We need to make sure that a determinant, which is education, we take seriously so that when women are educated, they can have the resources and the means to have fewer kids. It's not just simply what my colleagues in population science would say about availability of contraception. It is that, yes, but it is also education and a way out of that. So I think the combination of all these factors have led to poor health systems, poor ability to provide public health services, and it's been compounded in some states by insecurity because of poor governance, with the emergence of jihadist movements and unstable states, or military interventions producing governments that are unable to deliver for their populations. One final one, because we are in Berlin, and this is where the continent of Africa was divided into little groups, is to say the pervasive effect of certain European powers, especially in some of the Sahelian states, extracting wealth, extracting minerals, not paying a fair amount to allow people to develop human capital and good healthcare, but utilizing that with absolutely no regard for the consequence of what they're doing. I'll stop there.
And this is an impossible question. I therefore apologise in advance. If you had to give me literally your top 3 or 4 things that should be focused on in terms of the barriers to overcome to improve health in that region, what would they be? Unadorned, the top 3 or 4.
So I am not as pessimistic. I've painted a really bleak picture. I'm not as pessimistic. The Sahel is the region that had the Ghana Empire, the Mali Empire. When Europe was busy split between the Byzantine Empire and the Holy Roman Empire, we had universities in Timbuktu. We are as human as everybody in this room, right? And we have the intellect to organize. If some of those factors are explained, the interference, if human capital is allowed to grow, if people are educated, that massive youth bulge that we are worried about at the fertility rate, actually you could improve the determinants of health. So for me, one of them is education and addressing the levels and the skills and the potential. Second, the minerals available to the people of the Sahel that people are exploiting. If a fair wage is given and you can generate the economic revenue to do that, then yes, you can increase wealth and be able to do that. Third, the sun. The Sahara is a massive place, right? Sustainable energy. We could be part of the solution in the Sahel. And then finally, with good governance, provision of public health and primary health care would shift many of the conditions that are causing the absolutely dismal outcomes are fixable because they've been done in every other world region. And if we provide the necessary immunization, nutrition, and those services, we will transform outcomes for the people of the Sahel. Thank you.
Thank you. Ministers for Health and Finance, take note. So, Alakos Cieza, please. This GBD report shows us that non-communicable diseases, including cardiovascular disease, chronic kidney disease, cancers, diabetes, we could go on, now account for 75% of global deaths and 65% of global dailies. I think that change that Chris just showed you is really stark. And so that speed of this transition in low to middle income countries and upper middle income countries is really, really quick. Do you think, can you tell us what you think those patterns and drivers are of this epidemiological transition?
Look, the main message has been already said. The transition has happened or the transition from communicable diseases to non-communicable diseases has happened or is happening absolutely everywhere. However, it's happening in an accelerated manner in sub-Saharan Africa and South Asia. And we can see very clearly that transitions looking at premature deaths, deaths that happen before the age of 70. From all these deaths that happen before the age of 70, 1 in 3 is due to cardiovascular diseases, to respiratory to cardiovascular diseases, to respiratory diseases, to cancer, to diabetes, and kidney diseases. And we are talking about 17 million premature deaths every year. And to see the relationship or the extent of this impact, we need to think that approximately, and that is every year, approximately the same number of people died associated during COVID-19 in the 3 years of the pandemic. Globally, I said 1 in 3 of these premature deaths is due to NCDs. In Sub-Saharan Africa is 1 in 2. In South Asia is 2 in 3. And the drivers of this accelerated increase, especially in these regions, is cardiovascular diseases, diabetes, and kidney diseases. And women are also in these areas, in these low-income areas, dying earlier than men due to those conditions. The transition, we can say also this transition in the DALYs, as Chris also showed. And actually, from the perspective of NCDs, it's extremely important to look at the DALYs, because it is not only about the years of life lost due to these conditions, but the years that people spend living with the consequences of these conditions and in poor health. And it is important, especially from the perspective of NCDs, because they give us also a sense of the need for services for management and continuous management of these conditions. And if we do look at DALYs, as Chris also showed, the results are the same. There has been an increase due to mainly to the same conditions, to cardiovascular diseases, cancer, respiratory diseases, diabetes, and kidney diseases. However, this increase on DALYs has been steeper in Sub-Saharan Africa and South Asia. And again, the drivers of this accelerated increase, we can see, especially in the DALYs ladder that has been in diabetes and kidney diseases. So with this, these results, it does not come as a surprise when we look at the drivers, and also Chris shows those that cardiometabolic diseases are becoming the main drivers of poor health. High blood pressure continue being the number 1 in the ladder for non-communicable diseases. Obesity and blood sugar, again, has become a steep increase in attributable risk of poor health. Then also smoking, and of course, particulate pollution that is also on the top of the ladder. And even if smoking has improved everywhere, not at the scale of what it would have been necessary to compensate for the cardiometabolic risk.
I think there's a prescription in there, isn't there, for policymakers in terms of where they should focus. Now, one of the challenges we have in this session is there is so much material with each of our panels that we could talk about. We could take the entire session with any one of our panels, but we have 3 panels to get through. No pressure. And much as I would love to ask all of our panelists other questions about this, I'd suggest that all of you importune them at some point over a coffee break and ask them the particular thing that was on your mind. So can I ask you all to thank this first panel for those insights? We now have an opportunity with the QR code, and can I ask my next panel, please, to come up and join us, panel number 2. Where's the names? Damien, Emanuela, and Michael. There they are. Fantastic. Thank you very much. Yes, you may have a labelling problem. An identity crisis is going on right here and now. It's all good. They know who they are, and we'll make sure we do know who they are. So please take the opportunity to use that QR code to join the live poll. And while we're just introducing them, can I just indulge myself a tiny little bit? Some of you know that in addition to chairing IHME, I chair the CEPI board. I've been handed a note while we've been here today. We've already talked about the importance of vaccines and some issues in respect to vaccines. While we've been here, the German State Secretary on behalf of the German Federal Ministry, Research, Technology and Space has just announced a new pledge for CEPI 3.0 of 100 million to support CEPI's work over the next 5 years. Can I, with an indulgence, and thank you for indulging me, just really endorse and thank Germany for their renewed commitment. This work is so important to secure our future and to help prevent future epidemics and pandemics. So I am delighted with that announcement just now. Right, we're now going to go to our second panel, and Chris has his slides ready to go.
Thank you, Jane. And we will try to make this work. Next slide. Oh, there we go. So, in the GBD, again, these are images that you can all access and use from GBD Compare. So on the left panel is the share of burden that is from mental disorders, which is going up in all of the World Bank income groups, with the most marked increases actually in low and lower middle income countries, but certainly rises everywhere. And on the right-hand side of the panel is just the leading causes by age of that mental health burden, which are really depression, anxiety, schizophrenia, and then there is smaller contributions from the list that you see on the far right. So that's some of the story of the rise around mental health that we'll be hearing about in a moment. Temperature. The GBD for a few cycles has included both cold and heat, and this is the number now. I'm switching metrics to be the number of deaths from heat by World Bank regions, where both, because I'm showing numbers, in purple, the sort of lower middle income contribution, the increase is the largest in absolute terms. On the right-hand panel is the age distribution of heat-related deaths, which span injuries in green, respiratory infections and TB in red, and then dominantly cardiovascular diseases and diabetes in purple. And if you want the sort of high-level view, the number of heat-related deaths in 1990 were about 250,000, and there are about 550,000 in 2023. Overweight and obesity, another key driver, and Kroos spoke about this in the previous panel. This is going up on the left-hand side panel. This is the share of burden due to overweight and obesity, going up everywhere. There's nobody that is not experiencing this increase. And on the map on the right, you can see the fraction of burden in 2023 that's due to overweight and obesity. And all the places in red, more than 10% of burden is overweight and obesity related. And then the last slide, no, 2 to go. In the GBD 2023, with new evidence, published studies that were incorporated, we realized that the burden from lead, where the red arrow is pointing to, is now a much larger than previously assessed. So lead is now the 10th leading risk factor, and you can see the causes are mostly ischemic heart disease, shown in light blue on the right-hand side by age. And finally, in this GBD Compare review, is our new evidence that was put together on the sexual violence against children affecting many, many causes than we previously understood based on new systematic reviews and evidence scoring. There are 14 different disease outcomes that can be traced back to sexual violence against children. So over to you, Jane.
Thank you so much. Now, before we go to our panel, we might just ask to see the results. I'm hoping everyone used their device, and here we go. So, unsafe water, sanitation and hand washing at 54%. Ambient air pollution at 24%. So, thank you. Thank you for your participation. That's really very much appreciated. So thank you. Let's now turn to our very distinguished panel. Damien Santamoro, who I think is a compatriot. I might be wrong. Emanuela Garrido, who I think is known to all of us, and of course Michael Brower. So, Damien, can I go to you first?
Of course.
Thank you. So the results on mental health disorders, and I think it's probably something that all of us are very familiar with. It is subject to some comment in the general press as well as in the academic context. And I think all of us are particularly conscious of that in the issues both before and after the pandemic. So anxiety, depressive disorders, and particularly the impact on young people and adolescents, again, I think is something that we're all very familiar with. So can you talk to us a little bit about those trends and patterns for adolescents? What do we think is the scale of this issue? What do we think of the drivers? Growing burden question. Reversible question, over to you.
What we're seeing at the moment is an unprecedented level of prevalence and burden of mental disorders among adolescents and young people. And this is primarily driven, this has actually gotten to the point now where the peak of the burden of mental disorders is now in the 15 to 19-year-old age group. Previously, we estimated this to be in the middle age, but now it's within youth. This is primarily driven by increases in depressive and anxiety disorders. For example, globally, what we estimated in GPD was, compared to 2010, anxiety disorders in this age group increased by almost 70% since 2010, and for depressive disorders was increased by almost 30%. So these are very large increases that we're estimating here. Now, a large part of this was what we estimated as an impact during, or a bump during the COVID-19 pandemic. So for this work, we compiled data collected during the pandemic with comparative pre-pandemic baseline data, and we use this in our modelling to quantify what the impact of the pandemic would be on the population. And that's where we see the spike, particularly in youth. And this makes sense to us. This is a time of where there's supposed to be intense social development, but instead they were in lockdown or averse to socialising because of fear of the illness, depending on whether it was a lockdown location or not. There were issues with employment for youth and young adults because they tend to be more likely employed in casual, less secure situations. And so it's very, this was a time where they're supposed to be socialising with each other, supposed to be seeing each other, but during the pandemic, most of their social interactions would have been through digital means, if any at all. So it makes sense to us that there would have been an impact during the pandemic, and that's what we've modelled here. But at the same time, we've also seen in some regions around the world an increase that is evident before the pandemic. So particularly Australasia and Western Europe really show this trend, but we see it in other places around the world as well. And there are some explanations. When it comes to exploring this, my instinct is first to go, okay, well, what are the risk factors that we model within GPD for depressive and anxiety disorders? And Em will go through the risk factors in more detail, but for depressive and anxiety disorders in particular, we've got in GPD, it's bullying, intimate partner violence, and sexual violence against children. But when we look at the temporal trends for those risk factors, they don't align with the temporal trends we're seeing with the mental disorder prevalence and burden. And then when we look at how much burden they explain, it's not even a quarter of that burden, which makes me think something else is going on here. I then reflect, okay, well, what is it about this population, what is it about youth and their experience today that is different to, say, 15 years ago? And I think everyone in the room knows what the answer to that question is. And I do believe that social media, and I believe the cell phones, are having a detrimental impact to mental health of youth. The problem is the data drive, or that we have to inform this, does not really pass muster for inclusion in GBD as a risk factor. For inclusion of a risk factor in GBD, we really need strong evidence of a causal direction. But all the evidence on social media is associations. It's just, questionnaires where they say, oh, how much social media have you used and what are your symptoms of depression and anxiety? This does not emphasize causation. It's just an association. You could be more likely to use social media if you're feeling depressed or anxious. So we can't really use this. And then the effect sizes, or the magnitude at which these studies are suggesting that social media would influence this prevalence, is weaker or smaller than I would expect. And I think it's underestimating the effect, because when these studies are being conducted, it's in a world where everyone is exposed in some way. We're living in a digital age where social connectiveness between us is substantially reduced. And we know that social cohesion and social support is a protective for mental health. But this I think, has reduced substantially as a result of people's reliance on social media. People aren't seeing each other as much. People aren't talking to each other at the bus stop anymore. People aren't seeing each other, they're just liking each other's posts, or they're sending each other a TikTok video or something, and that's what keeps the relationship alive, but they're not emphasizing, they're not building that relationship that really would be protective of their mental health. And what's interesting is that Australia has recently introduced a law that actually bans social media for people adolescents under the age of 16. I think everyone needs to pay close attention to this. It's a very interesting experiment, and I'm really interested to see if there's any evaluations out of this, because if it's successful, maybe it's something that should be implemented elsewhere. In saying that, I don't think it's the only factor at play. Now, I was thinking of other risk factors that could be at play, and there's 3 that came to my mind, and the common theme across the 3, even though they're very distinct from each other, the common theme is a hopelessness for the future. First of all, this generation experiences quite a substantial climate despair. We're seeing, evidence of climate change with not much action occurring. So youth today are even wondering, what kind of world am I going to be living in? Is it worth raising a family in? Is it worth even planning my future? And so what would that do to your mental health? If you were young and you thought that the planet was going to look very different in 50 years' time, would you invest in your mental health? Would you feel hope for the future? The second is war and conflict. Now, we've seen lots of atrocities lately. It's all over the news. Of course, we know that war and conflict has a substantial impact on mental health of those populations, and will also be impacting, again, through social media, the spread of those images that we see every day that would not have a good impact on our mental health. But also, there's the prospect of war and conflict in the future. The rhetoric at the moment is everyone's riling up for war. Imagine you're a teenager today, and that's all you're hearing. What hope would you have? What would that do to your mental health? What would that do for your future, for your perception of your future? And lastly, we also know that employment and financial stability are protective of your mental health. And if you lose your job, you're more likely to develop a mental disorder after you become unemployed. Now, when we look at youth, there's an unemployment crisis there. Youth are already struggling to get work, and when they do, there's a financial crisis, cost of living crisis, there's a rental crisis, a housing crisis, depending where you are. So they struggle to get work, and then when they do, they can't make the same financial goals that previous generations have made. And so again, what hope would they have for the future? Imagine what impact that would have on your mental health. And then with the rise of AI, if you're young, you start a degree today, you don't even know if that job's going to exist by the time you finish your degree. So when you're trying to plan your life into the future, what does that do for your mental health? I know for me that wouldn't be very good for my mental health. Now, I appreciate that these are factors that are very hard to address. They would really require, collective leadership at the global level. So I guess from a pragmatic sense, if there's one area or one lever that is easy to target, it would be mental health service provision. Mental health service provision is still very, very low. We've had tremendous gains, but it's still low. We did some work that was published last year that estimated that among major depressive disorder cases globally, only 9% accessed minimally adequate treatment. Well, that's less than 1 in 10. And within even high-income regions, that's not even a third of cases of major depressive disorder. So they're not accessing the treatment. I don't think this is quite good enough. So if there's any lever that, from a local perspective that you've got control over, this would probably be the path of least resistance.
And just a little local colour on that under 16-year-old ban. When we introduced plain packaging, the first country in the world, which we did when I was Secretary of Health, there were a lot of large corporations who did not like it at all. It won't surprise any of you to know that the corresponding large corporations do not like that ban. But the good thing is our government is quite resolved, which I think is a good thing. Thank you. Now, given you've mentioned one of those risk factors as being in respect of sexual violence in particular, I think I might turn, Em, to you, if I could please. And because the GBD actually does have the obesity, sexual violence against children as both major and probably often unrecognised factors. And I think many people in our community would be surprised to hear how much of a risk factor that they are. And it's not only in high-income countries, it's in other countries as well. So if we do think this sexual violence against children drives the significant mental and the kind of physical health challenges, what should leaders do? What should people running health systems and other relevant systems do to act on that challenge?
Yeah, thank you, Jane, for recognizing the importance of sexual violence against children. I'm going to add to that intimate partner violence and other forms of violence that have gone underappreciated and under-recognized. And I'm very pleased with the GBD 2023. We've been able to improve the measurement. And if you, those of you that have scanned the QR code and you go to GBD Compare, it is shocking when you look at the risk factor review how high these risk factors rank for the first time, because we've been able to improve the evidence base behind them. That said, whatever is there is very much an underestimate of the true prevalence and the true burden for many reasons. Part of it is in the GBD, we're currently only measuring 2 forms of violence. We have not even touched online cyber violence. Damien talked about social media. A lot of that happens online. And also, it's a field that has historically been understudied. So the level of evidence linking exposure to sexual violence, intimate partner violence, and a lot of health outcomes is very sparse. So being a data person myself, one of the things that I would say we have to do is improve the evidence base. It's a really difficult field to measure. I have dabbled in many different fields throughout my career, and this one has been the most challenging to measure accurately and do justice to the magnitude of the problem and its consequences. So I would say definitely invest in better measurement and quantification of the size of the problem. But we don't need to wait for that. If we look at women of reproductive age, so one of the views you can look at on GBD Compare is the age group 15 to 49. You look across the globe, Sub-Saharan Africa, high-income region, any region you want, intimate partner violence and sexual violence against children are among the top 5 risk factors for women. So if you want to do something about maternal health, reproductive health, health of women, you can no longer ignore it. We have now quantified among the top 5 risk factors. It's not in one country, it's not in one region, it's global. And part of the reason behind it is also its exceedingly high prevalence. So we're talking about 1 in 5 girls, 1 in 7 boys who are now adults were exposed to sexual violence as children. For intimate partner violence, the estimates are in the magnitude of 1 in 3, 1 in 4 adult women. So these are very big, important drivers of health. And I think in global health and ministries of health, they have not traditionally considered them as health challenges. Damien also spoke about the lack of availability of provision of mental health services in many parts of the world. And we saw that the burden from violence, exposure to sexual violence, intimate partner violence, also is concentrated in a lot of mental health disorders, but we're now also seeing it come up in conditions like asthma and conditions like diabetes. So when physicians are treating a woman of reproductive age with a condition, I think it's important to raise awareness that one of the drivers might be exposure to violence, because the mechanism to improve the health and well-being of those survivors might be different than somebody with that condition who has not been exposed to violence. So I think there's a lot of room for improvement and a lot of room for optimism once we recognize that this is a very huge problem that has gone underestimated and emphasized.
And there's that trick that everyone plays at conferences, isn't there? So Em just gave us a figure of, 2 or 3 out of 4 potentially experiencing these circumstances. It's a very large proportion. So you can look left and you can look right in this room and go, how many women in this room are experiencing this kind of things? Now, this is the impossible question that I'm going to ask you to answer briefly. So this is my point. There's so much material in the GBD. Obesity. It's that leading cause now of DALYs in a number of regions. I struggled with this as a policymaker, and I can't see any country that's had really any success here. Do we just give up? Well, we can't, can we? We cannot give up.
Absolutely not, no.
We cannot give up. So, what are we going to do? What are the priorities?
Okay. I think if we really want to see a change in obesity, we need cultural change. We need to no longer think that it's socially acceptable. We need to recognize it for the disease that it is and all its health consequences, and seriously put all of our resources to tackling it. We have exciting developments in the pharmacological treatment, but that's not sufficient, and that's not going to reverse the epidemic. And I think Zulfi mentioned that we have been neglecting the age group 5 to 14. That's the part that worries me the most. If you see the increasing trends in overweight and obesity among children, we as adults have failed those children. And it's definitely reversible before those children become obese. So we have a window of opportunity, particularly for young individuals who are overweight, to prevent obesity. But I really think we just need to fundamentally change how we have been approaching obesity, because it's not working. We have irrefutable evidence that it's not working. So it's time for a fundamental change. Maybe it's cultural, social acceptability in combination with pharmacological treatments, and an approach that spans everybody, because it's also rising everywhere. The levels may not be the same in every country, but there is no country where obesity is not either a current or an upcoming problem.
And not everyone will be able to access this pharmacological treatment.
Not quite yet, but hopefully. I would like to be optimistic, but even in a scenario where pharmacological treatments were widely available, I just don't think they're sufficient for the magnitude of the problem and the trends that we're seeing. We need more than that.
This is a conversation which I suggest you have as you eat lightly at lunch, morning and afternoon coffee. Michael, the other big one, of course, is the environment here. Ambient air pollution. Chris called out the lead information, something which I think took a number of us by surprise. It certainly did me. And extreme heat, I think we are conscious of that, but they're all contributing factors in the results that we're seeing. And then other things that we don't always connect into the environmental issues like dementia. So there were a number of things I found surprising. What were the things you found surprising?
Yeah, I think three aspects to this that surprised me, even though I've been studying this for decades. First is just the sheer magnitude of the impact of these environmental risks on disease burden. 7.5 million deaths in 2023 from air pollution, 3.5 million deaths from lead exposure. And these are also risks that I would say we've known about for a long time. Lead has been known as a harmful substance since Roman times, if not before. But still underappreciated, and really underappreciated in the sense that we know how to solve these problems and just have not done the implementation that's been necessary. Secondly, I think continue to be surprised by their impact on NCD progression. I think we tend to think about environmental risks. We tend to get concerned about them when we see them. When there's an episode, an extreme heat event, a severe air pollution episode, uncovering of massive lead exposure in a municipal water supply, something like that. But these are really affecting each and every one of us every day of our lives. We think about something like extreme heat. Now we have children that are having multiple episodes every year of their life, and we just don't know what the impact of that's going to be. We're in a new era with that. And then the third surprising aspect, and this really continues to astound me, is the breadth of diseases that are affected by these environmental risks. So air pollution is linked now to, I think, the 8 leading causes of death that we assess in the GBD, and you mentioned dementia. I guess when we started that work, I was quite skeptical that we would see a solid relationship, and yet again, there it is, and it's really holds up. So the same thing, the slide that Chris showed on temperature, the magnitude of diseases that it's affecting. So everything from infectious diseases, respiratory infections, injuries, self-harm, homicides, to then the chronic diseases, so cardiovascular disease, for example. So there's these 3 sort of aspects. It's large, it's affecting multiple diseases, and these are the diseases that are the main killers today.
And I think for any policymaker in an aging population, these are things that you really do, and they're not being talked about from a policy perspective. Just in terms of the increase in heat, how much, and the deaths numbers which Chris has taken us through, 2.5, the next coming decades, where are we going?
Yeah, I think, so 2 aspects of this, and I'll come back to this impact on NCD progression, is that and I'll just take the example of air pollution. Even if air pollution, we have had some successes. So for example, household air pollution from use of solid dirty fuels for cooking has really dropped considerably in much of the world. At the same time, ambient air pollution is stable, perhaps peaked, and maybe starting to go down, but that's absolutely insufficient. And it's insufficient because we have this aging population and increasing just numbers of NCDs. So we need to do much, much more. So we have really colliding forces here. And then heat is, unfortunately, it's a bad story because we're seeing this increase in these extreme heat events. We are starting to look at that in the GBD framework and look into the future, and it's going to be big, and it's going to be big especially, as was mentioned, in places like the Sahel, where we have multiple factors sort of coming together. And while we've been quite effective in high-income countries in dealing with extreme heat through air conditioning, that's just not going to be accessible for much of the world's population. So we're just at the start of this, and unfortunately, that picture does not look that great.
And unfortunately, again, there's so much here that we could talk about. And I'm a bit worried, given Damien's earlier remarks about, a completely negative outlook on what it does to your mental health, to leave the discussion at that point. But I am going to have to because of time. So look after each other and your own mental health. But can I ask you to thank our panel? And again, while we do our rapid turnover, thank you, panel, we have another QR code. So can I welcome our new panel to the stage, please? Irene, Ximena, and Richard. And why don't we have Irene first? Thank you. Ximena and Richard. Richard's going to get sort of the last word, which would be somehow appropriate. So has everyone done the QR code and filled in that one? Yes? No, they're still doing it. I'll give you the results when Chris has finished his remarks. As soon as we've got names, so people don't have an identity crisis.
Okay. Just a couple slides where we're shifting gears to not about the main results from the GBD, but the value to other dimensions of global health of having a standardized, curated data set like the global burden of disease. So a number of years back in the GBD, we took the work of Martin McKee and Nolte on amenable causes of death and designed an index of healthcare access and quality. This gets produced each cycle with the GBD. And that index is based on the premise that if you risk adjust, using all the risk factors that we've talked about in the GBD, mortality for certain major outcomes that are healthcare sensitive, that becomes a meaningful measure of access and quality. And these are the results for 2023 on a map. The access and quality measure is scaled from 0 to 100. And you can see places in Europe and Australia that with the highest level in 90 to 100, and on down to levels of healthcare access and quality that are in the 20 to 30 range in a number of low resource settings, both in sub-Saharan Africa, but also outside sub-Saharan Africa as well. Now, the same data, by the way, is used from the GBD to look at universal health coverage, but more of that focus is on looking at delivery of interventions or coverage of interventions. The thing about healthcare access and quality, this measure, it is very outcome-based, although we do try to control for things outside the purview of the health system. Now, you can take that information in the GBD, outcome, or healthcare access and quality, but in this case, using healthy life expectancy. This is a paper published in Lancet Global Health in August, so not in the issue that you can get as you leave, but shows you the way we can use outcomes, healthy life expectancy in this case, spend, and start to ask the question, which systems translate money or healthcare expenditure into improved healthy life expectancy more or less. And you get some pretty interesting, intriguing relationships where countries in blue, for their level of spending, which may be very low, are closer to the best healthy life expectancy that's observed. So a country like Burkina or Niger stand out, or Tanzania. And then countries that are far from the best that you can achieve with their level of spend. And one that springs to mind here that is one of the highest spending countries in the world, namely the United States, and it looks that it's quite far from what's possible in terms of healthy life expectancy. And I think there's a lot of actual and potential applications of this curated data on health systems to derive hopefully transferable insights about health systems in the future. Back to you, Jane.
Thank you. So for any policy wonks in the room, there's a lot to take from this. Now, we've got a terrific panel for this particular session. Irene Aguirre will join us, Ximena Aguilera, and of course, the one and only Richard Horton. So Irene, can I start with you? Health systems, low-income, middle-income countries, particularly in Africa, you've had a lot of experience in those contexts. So in addition to the kind of epidemiology, oh, I'm so sorry, I've missed drawing your attention. Just hold that thought. So there we are. Expanding access to healthy diets and physical activity. Wins overwhelmingly in our Slido. Thank you for putting those up. So Irene, coming back to thinking about the transition that's underway throughout the world, what do you think some of the challenges for low to middle income country health systems are? I mean, what do we do in those contexts?
Well, thank you, Jane. I think there are so many things, but let me just do two.
That will do. Let's start with 2.
Okay. I think there's the old continuing challenge of resource availability. There's nothing new there. But on top of that is the continuing question that if I only have so much, how do I optimize what I get out of it? And I think some of it comes back to the last slide Chris showed. And I think also on top of that, I would raise the issue of, does it always have to be either or? How do we enable more collaborative problem-solving, out-of-the-box thinking approaches so that sometimes it might just be possible that it doesn't have to be either or? If I can just use an example from my own country, when we were thinking through how do we get rid of out-of-pocket payments, can we do national health insurance? The global consensus was low-income countries, sub-Saharan Africa, it's almost impossible. We spent hours and hours brainstorming. What do we do? At one point, it almost fell apart because 2 very powerful players, one felt it has to be classical social insurance, employer-employee, and another powerful player said, how on earth do you do that when only 20% of the countries in the formal sector? In the end, we only jumped that hump because we dropped the either-or thinking. And we ended up with a scheme which has a bit of everything. And people kind of just decided to, let's just do what we can and forget about. So that's an example of that. I think the second issue I would like to raise, and it's both a threat and an opportunity, what do you do with dwindling global support? Because global support has made a huge difference, and I'll use the example of immunization because I have a very personal interest. My mother's generation feared measles.
Yeah.
In fact, my little sister died of measles, so I also feared it. There was no EPI program in my country back then. As a young doctor, I remember my pediatrics rotation. In fact, when I saw the pictures from New York of COVID, I said, that's my pediatric rotation as a young doctor. You had children coming in and dying, and sometimes they are forgotten on the trolley because everybody's overwhelmed. It's all gone. Mm-hmm. The young doctors of today in my country have never seen a case of measles. Mm. And I think, sometimes when you are not afraid of something, it's because somebody else has cleared the threat. Is the world going to wait to see this threat again before we realize what we have lost? And in the session in the mornings, I think one speaker said health is a global good. It is. It's a bit like you throw a stone into a pool. The ripples go well beyond where you threw the stone. So those would be my 2 comments, and I stop for now.
Thank you. And thank you. I think we all know there's a couple of natural experiments going on in this space right now. So if you think about the findings, both in terms of what we've seen in terms of the epidemiology burden and some of these health system findings, so what would you say to health system leaders about what they should do with this information? How useful are they going to find it? What can they take from it, do you think?
Okay. I'll start, we have a proverb in my language, I'll translate it, which says, Namdodo on saying kwai. Basically, what it means is that you can't ruin a soup by adding more meat. You can ruin it with more pepper, onion, salt, but generally not by adding more meat. I think for health systems, I really think it's hard to ruin a health system by getting better data, better analysis, absolutely, more availability. So I would say that this is hugely important to health systems, not only because of the results it's showing, but even in providing advocacy for how can you up your routine health systems. And I think earlier somebody mentioned the fact that part of the worry now is there's no more demographic health surveys. It is an opportunity. How do we put more thinking into some of the routine data systems that are so valuable to efforts like the GBD that in low middle income countries sometimes are on the margins of our thinking. And it's a bit the problem of, in a low resource context, it's harder to do long-term thinking. You are so busy trying to survive that you are just focused on what shall I eat today. Whereas some things are really building your production capacity.
Yes.
You may eat a little less today, but you have more sustainable food tomorrow. Thank you.
Thank you. And we did see, didn't we, essentially in the results, what you can see in the future. Well, we need to start anticipating that coming down the pie cutters. Ximena, Latin America, rapid shift,
Very rapid.
very rapid.
30 years.
Yeah. Obesity, fasting plasma glucose, leading risk factors. And of course, we've still got the issues around infectious disease. So we've got that dual burden that we're dealing with. So what are the interventions that are being thought of in this context, particularly in Chile, but more broadly in Latin America, to actually think about this transition? Are there things that are happening there that you feel positive about or you want to talk about, or what isn't happening that should?
Well, I think that it's true that Latin America has this rapid transition. I am from this long and narrow country that you see in the map from Chile. And this rapid transition gave us the double burden of infectious diseases that still are not resolved in the continent, and the increased burden of non-communicable diseases and mental health that was shown in the results. The first thing that I want to comment is to realize that the health system is important. It's important what we do with the health system. Also, it's important what we work in the cross-sectoral activities. And also, it's important to accept or to implement innovations in the health system. So there's these three areas to work. First, intersectoral and legislation is very important to tackle non-communicable diseases. We have been working on that in Latin America. For example, the control of tobacco, the Convention of Tobacco, all the global work and the global environment to move forward to this legislation has helped. The examples from Australia, for example, has been improved, put there. And that is the contextual of our policies. We cannot tackle any diseases alone as a health system. But the health system could be improving their outcomes, as Chris showed, very different kind of behavior and results, outcomes from the health system related to the way that you organize the health system. In our case, in the region, and especially in my country, for us, primary health care is the backbone of the system. It's the most important thing, because with the primary health care, you can reach the population, and coverage is the first thing to have any kind of different results with health system. In the case of my country, we this year mark 20 years since the creation of our explicit health guarantees scheme that was based on the burden of diseases. We worked on this 20 years ago, is updated every 3 years, and we include in this health system of guarantees, health guarantee system, guarantees to access, to timeliness of care, out-of-pocket protection, of financial protection, and also quality. And now this package this year is going to rise to 90 health conditions, that is 80% non-communicable diseases. This package, huge package, built based on evidence that is delivered mainly through primary health care, allow us to implement evidence-based knowledge in a population manner in the health system. And we have had good outcomes of that. We still have many problems, of course, like any country that is everybody is going out from the pandemic, that is huge disruption in the health system. But still, these 20 years of implementing this evidence-based intervention based on the burden of disease, on feasibility, also in the adaptation of the responses to the local level in primary health care has allowed us to improve our situation to reach a very high expectancy of life and to have good results. Still, you cannot abandon infectious diseases. Still, it's a small burden, but still there's a space to work in health system for interventions that we know that are cost effective, but we need to put them in the population. And that's why primary health care is key. It's key to reach our population with this intervention that are that we know that had the better outcomes. And related to innovations, there's a lot of new technologies over there. And we have to innovate. We have to be responsible in the way that we introduce innovations in the healthcare system. We have been working in health technology assessment, in the risk-sharing agreements with the industry that allow us to for example, to implement in a universal fashion the monoclonal antibodies against respiratory syncytial virus. With that, we have 2 years with zero death in children under 1 year old because of this virus. That is incredible. It's expensive. But in the same year, we worked this with a finance minister. In the first year we put the antibodies, we we recover more than that we invest in the first year of implementing. We are also implementing protein modulators for cystic fibrosis, pulmonary diseases, and also immunotherapy for cancer. But that means that you have to work also in very responsible manner with economic and also efficacy evaluation of what interventions are the best to implement in our health system. So that's the main things that I wanted to say to this related to this question.
So when we talk about interventions and we talk about things that work, how do you combine, things like promoting the things that won on our poll just then, healthier diets and lifestyles, with that primary care improvement to help manage this NCD burden, this challenge? So what do you see as being the way to bring those things together?
Well, I think what amazed me of these results is mental health. I think that mental health is something that is urgent. The burden in children is huge. And that called me the need to integrate all these different approaches in the response of the health system. I participate in the social connection, what's the name of the commission, as a commissioner with Lancet. And we work with WHO in the burden of isolation and loneliness in the population. And one of the findings is the huge sense of isolation and solitude among young people. That's something that is striking, because when you think about solitude, you always think about elder. But in this report, we found that in the children, it's very important. And also, we all of us experienced the isolation during the pandemic, that it was another natural experiment that also tend to make more severe the mental disorders. So we pushed for a resolution in the Assembly with Spain to integrate social connection in the policies from in our interventions. And I think that is something that we have to continue to explore, to integrate, not only working on diet and activities and risk factors without considering that we need the human connection between each other, to integrate in a transversal way the connectivity, the social connection, and that helps us in the children, for example, not only for mental health, but also for obesity. That is something that we have failed as a global failure in obesity. And I think that one innovation that we can put in the new way to structure our activities is considering this work to integrate the social services with health services in primary health care. We are working on that actually in our primary healthcare system, universalization of primary healthcare, changing the focus of primary healthcare from population to territories, to have a resilient primary healthcare facilities, to work with disaster and epidemics, and also with climate change, and to integrate all these different areas that are important and are increasing in a global level, but also in all national levels, and in a hub that is primary healthcare. Why primary healthcare? Because in a country, primary healthcare depends on the local government. And that is the best part to work across sectors. It's not between the ministers, it's in the local level. Because the mayor has to deal with all these things in this territory. And we have to follow that with our health system, to believe more in the intelligence of that local level, and to work and allow them to work intersectoral. We are very vertical in our structure of the health system. We have to broke a little that and introduce these new risk factors, this integration with social services. We are an aging population, we require that, and we have to open that. And I think that the best platform for that is primary healthcare.
So very much a place-based approach. Interesting, thank you. Richard, we've heard already, the impact, and we've heard from a number of the speakers on the panels, the impact of COVID-19. We all know that we came out of COVID-19 really having been set back very significantly on things like the SDG goals. And we had a great level of ambition in 2015, and then we got knocked sideways by this experience. And a number of the things that our panelists have talked about have added to those difficulties. Can we use the GBD to help us set a new course, a new agenda to actually achieve those really ambitious objectives, which I don't think any of us resolve from? I think they're still important. So what's the ambition, Richard?
Well, let's, first of all, let's just pause, stop even, and rethink and reset. Because let's put this into context. So we had 8 Millennium Development Goals, 21 targets. Then we have 17 Sustainable Development Goals, 169 targets. So what's going to come after 2030? 30 or 40 development goals and what, 300, 400 targets? I mean, we cannot continue like this. We are constantly splitting and dividing and fragmenting and breaking apart our vision for the future instead of finding linkages, associations, dependencies, connections between all of these issues that we care about. So we need a new framework. First of all, however the GBD fits into it, we need a new framework. It's a framework, and you've seen it in your votes. Why do we separate food systems from health when we know that dysfunctional food systems, this was in the Lancet Commission we published last weekend, dysfunctional food systems are the biggest driver of planetary boundary transgressions. And we don't see food systems as part of we don't see it as part of a health issue. This is madness. We separate out gender from health, and yet we don't see gender justice as an indispensable part of what it is to attain the highest attainable standard of health. We have to bring gender justice together with health, not just have SDG 3 and SDG 5. We need to go beyond under 5 mortality. Zulfi mentioned this, to integrate adolescent health. We need to go beyond the climate crisis and think about other environmental threats, such as plastics and health. So we need a completely new framework for thinking about development. I don't have a perfect solution, but I would invite you. I would invite you to look at a commission we published earlier this year, led by Andrea Winkler and John Amoasi, that tried to redefine One Health, making it much more inclusive of non-communicable diseases, health systems, food systems, integrate, not split. Now, having said all that, don't despair, because it's very easy at a meeting like this and all the corridor conversations about how dreadful life is and who's going to be the next Director General of WHO. Where is WHO? And it's very easy to get depressed. We have an amazing opportunity before us. A year ago at this meeting, Global Health 2050, another commission, argued that we have the knowledge to be able to halve preventable mortality by 2050, and we don't need to wait for universal health coverage to win that success story. So we do have opportunities that we need to seize. However, I would just say, and this applies to whether you're talking about halving premature mortality or whether we're talking about the GBD, I love the figures and I love the mathematical magic of modeling. But unless we embed the mathematical magic of modeling in a theory of justice, then we aren't going to have a vision that's going to be compelling. And it's not just about the distribution of resources, it's about the distribution of power, and it's about recognitional justice. It's about recognizing the diversity of individuals and groups in our society, and that everybody, every individual, every group has an equal right to a voice in that distribution of power. So then we come to the GBD. Now, the reason why we at the Lancet are so committed to the GBD isn't because we want to publish thousands of papers. It's because we see the GBD as the most powerful mechanism for independent accountability in health today. And by independent accountability, I mean the ability to use science as a tool for monitoring, holding those with power accountable for the promises and commitments they have made. That's what all these numbers are about. So it should be no surprise that it was Maria Machado who won, as opposed to somebody else, the Nobel Peace Prize. Why should it be no surprise that the opposition leader won? Because if you go through all the tables in the GBD capstones, you will see that there are only 3 countries that have the dubious distinction of not only seeing reversals in under 5 mortality and reversals in life expectancy for women and men. Those 3 countries are Venezuela, Libya, and Palestine. It's not surprising that it was the opposition leader of Venezuela in her work to try and hold her government accountable who wins the Peace Prize. So the GBD has thousands of stories of hope and also, in some cases, despair. And they are all of these stories are departure points for action for all of us. Now, you might think, in today's world, which is all about anti-multilateralism and anti-globalism, any initiative with the word global in it is doomed to failure. I would just say to you, keep the faith. This time will pass. Prepare for the future.
And it's impossible to follow that. So let me simply say this. There is a world of opportunity in the GBD. We need to have hope, not despair, and we need to work together. Can I ask you to thank all of our panellists? And thank you for your attendance.